Welcome everybody to our Plum Health podcast. Welcome Dr. Abdul El-Sayed, running for U.S. Senate in the state of Michigan. Thank you so much for coming out today.
Honored to be here. Thank you for having us.
So big picture, can you tell folks why you're running for Senate?
Yeah. I ran for governor back in 2018. At the time, I said something that folks weren't quite ready to hear, which is that Trump is not himself the disease of our politics. He's just the worst symptom of the disease. And I know you and your listeners will appreciate a good medical metaphor. But the broader disease is the system that allows huge corporations, billionaires, would-be oligarchs to buy and sell our politics. And that's rendered a situation where it's just become too hard. It shouldn't be this hard to go see a doctor. It shouldn't be this hard to send your kid to a dentist. It shouldn't be this hard to send your kid to a quality school or to afford a bag of groceries that has healthy food in it. It shouldn't be this hard to take a big deep breath or drink a glass of water and know that these things are doing more for your body than they're taking away. And for all those reasons, I think we need leadership in the U.S. Senate that's going to drive legislation that helps to take the edge off of living in America that was always supposed to be of people, by people, and for people. And you know, I think right now in particular, it's just become so much more pointed around how our political process has failed us. And I think folks are looking for something a little bit different. And I was sitting in my office back in January on the day that Trump froze federal funds, looking at all of the items, line items in my budget as Wayne County Director of Health, Human and Veteran Services that had been frozen. So WIC, food on the table for moms and babies, federally qualified health centers, the last line of healthcare defense for a lot of folks who can't afford it, vaccines. And that was the day that our current U.S. Senator announced that he was not seeking re-election. He'd be retiring. So I realized that that's where the fight needed to go to the U.S. Senate, both to stand up against a lot of the damage that we're seeing from this administration and to stand up for a view in America where we actually fight for the kinds of things people need and deserve. So grateful to be out there. I've been at it now for about 8 months. We've done 70 different cities, 170 public events, and we go everywhere and talk to everybody. And so I'm really grateful for the support we've gotten.
Yeah, you mentioned something earlier about how things are hard to change. And one of those things that is so hard to change is healthcare. And so it feels like a lot of healthcare delivery is dependent on federal legislation and federal dollars. Can you talk about, you're coming in to bring forward this idea of Medicare for all. So can we talk about like how we got here and why things are so calcified in terms of making change in our healthcare system?
Yeah, Doc, it's rare that I get to speak to somebody who's A, understands the system as well, and B, has done their part to try and address it. Our healthcare system is broken for so many reasons. What we see of that is that healthcare is too expensive. It's inaccessible for a lot of people. We have tens of millions who are just frozen out. They're uninsured. For people who are insured, that the cost of that hits you every 2 weeks or 4 weeks. And then again, when you actually want to get your healthcare in the form of a deductible or a copay. And we're watching system-wide as the system just becomes more expensive and more unstable. We've seen a failure to maintain any sort of semblance of affordability on the system by the Trump administration, stripping away these subsidies for millions of people to be able to afford their premiums. And my worry is that because a lot of folks, mainly younger, healthier people, are losing their insurance, they're going to opt out of being in the insurance market. Insurance is a pool, right? You need a certain number of people who can pay in and don't pay as much out to be in there to cover the cost of people who need a little bit more care. And what's going to happen is those premiums are just going to spike again because those less costly people are going to opt out of insurance. Now, Medicare for All basically does a very simple thing. Instead of relying on the private for-profit health insurance industry to provide people health care, we want to offer a baseline guarantee for everyone in this country that covers the basic healthcare needs that you have without a premium, a copay, or a deductible. If you like your insurance through your employer or your union, you can keep it. But if you lose your job or your factory goes under, you're not stuck without insurance at all. And because of that baseline, that system would have the power to start negotiating on our collective behalf, bringing down the cost of prescription drugs, bringing down the spiraling cost of healthcare, And because it covers everybody, all of these bumps and bruises in our lives, the reasons you can lose health insurance because you turned 26 or got a job or lost a job or got married, got divorced, turned 65, those go away for you. They're just there all the time. And the last thing I want to be clear about is that our vision in Medicare for All isn't that you take the current Medicare and extend it for everybody, but that you improve Medicare. Because right now, Medicare is not as good as it should be. There are a lot of gaps. There are out-of-pocket costs. Medicare, which is a program that funds healthcare for people over 65, doesn't include vision, dental, and hearing, which I don't know anybody over 65 who doesn't need one of those three things. And the idea that it doesn't include it is kind of ridiculous. So we would be improving Medicare and extending it for everybody. And I think that could help to solve a lot of the biggest structural issues in our society. Now, look, a lot of folks say, well, you can't get it done. Well, with that attitude, sure, you can't get it done. But so long as we continue to allow our whole system to be focused more on profit than it is on patients, we are going to continue to struggle without the healthcare we need and deserve.
Yeah, I think those are all great points. The pointed criticism from maybe physicians or more independent-minded or more libertarian-minded folks would be, well, I don't want the government running my healthcare. The government struggles to run things efficiently. Can you talk about how a government-run healthcare could be more efficient than the current insurance marketplace?
So the first thing I want to say is it's not government-run health care. It's government health insurance, right?
That's right. Yeah.
And we already do this for the people who need insurance the most, people over the age of 65. And we do it quite efficiently, right? Way more efficiently than the private health insurance industry does it, right? In large part because it operates at a 3% overhead, right? The health insurance industry, private health insurance industry operates more at a 15% overhead. So it's already more efficient for the people who need the healthcare the most. Now, let's be clear in this country, 60% of all healthcare that is given in this country is funded by the federal government, right? Or the state government. This is just how it works. We just wait until you're older to provide it for you rather than providing for you your entire life. And I actually think it's critical to being able to free up access to a real quality healthcare market. Because here's the thing. Right now, the way that healthcare gets provided, the reimbursement rates for the care that gets given, right, the stuff that doctors and hospitals do, that is negotiated between private health insurance companies and providers. And it's negotiated not on
and providers include hospitals, clinics, individual doctors,
even pharmaceutical companies,
and nursing homes.
Yes.
Yep.
And those negotiations are completely opaque, right? And they're usually negotiated, right? These terms are usually negotiated for the betterment of the insurance company and for the betterment of the large system, usually the large systems.
Yeah, the largest hospitals have the biggest negotiation power.
Exactly. So if you're the biggest one, you can command the best reimbursement rate, which means that if you're a great primary care doc and you want to be able to compete in the market, it becomes a lot harder for you because of the power of your competitors. I just don't think that's right. So one of the things that Medicare for All could offer is a transparent reimbursement rate that is the same across the board. That means that if you want to shop your care out there and you got a really innovative idea or innovative strategy for providing care, maybe like direct primary care, that you can go out and you can compete without having to worry about whether or not your large competitor is being able to command more money for the same exact healthcare that they provide. And so I argue, I'd say that for most doctors, if you look at the way healthcare has gone, most doctors now work for a large healthcare system. They no longer work for themselves or work for a physician-owned practice. That is because of the power of the health insurance industry to start setting the rules against the smaller players. And Medicare for All could help to create rules or reset the rules so that the small guys can compete as well. And so if you believe in a healthcare market, you want even playing field for everybody. Medicare for All could offer that. And one of the problems I would argue right now is that I think direct primary care is a really great model. Why? Because you get to know your doctor, and that doctor has an incentive to think about your care over the long term, not just in one iteration or one interaction that they have. And I think you talk to most patients, they'll tell you the biggest frustrating thing about getting healthcare in this country is you don't have enough time, right? The doctor doesn't really know who you are. They just interact with you within a chart. They want to push as much of your care as they can into some portal rather than actually interacting with you.
Or your primary care doctor is so time limited by their number of patients that they're referring everything to specialists. It increases your downstream costs.
Exactly. So I think we could we could think about how do you build a direct primary care model into, right, a Medicare for all system. So, we use Medicare so that folks can kind of understand, okay, it's a system that operates for everybody, kind of like Medicare for people over 65, but we don't want to recreate the same challenges that current Medicare has. We want to improve Medicare and then extend it for everybody.
Indeed. Yeah, and that would come up to my second most pointed question, which is, okay, doctors like myself who embrace this direct primary care movement, we bill our patients outside of insurance, we don't bill or use insurance at all. And to stay compliant with federal regulations, we all, as direct primary care doctors, have opted out of Medicare, so we don't have any risk of being accused of Medicare fraud or double dipping. Let's say if I worked at an urgent care to pick up shifts and make money while I'm starting out my direct primary care practice, I couldn't see any Medicare eligible patients in both places. Otherwise, I'd be committing fraud, right? Because I can't bill outside of Medicare. So the pointed question is, how is Medicare for all going to work when you have doctors who are opting out of Medicare because of decreasing reimbursement over time?
Yeah. So I think we have to fix the reimbursement problem.
Yep.
That's the most important issue.
Indeed.
I think one of the hard parts right now is that you have this multi-tiered reimbursement system. So we're getting in the weeds here for folks, but when a doctor does healthcare, they bill, and then the bill is a function of a pre-negotiated price. Right now, what happens is if you bill Medicare or its cousin Medicaid, right, those reimbursement rates are so much lower than private health insurance, which is a problem. So I think we need to improve reimbursement, in particular, improve reimbursement for primary care. One of the other issues is that there's such different reimbursements for specialist care versus primary care. And I think we need to rectify and improve primary care reimbursement. So what I'd love to do is sort of think, can you include a direct primary care model into Medicare? Can you do that in a way where that's sort of an opt-in? You could actually even think about it as like a monthly direct to the provider for full scope coverage. But also, if you want to do the old-fashioned model, at least the reimbursement rate is fair and high quality, and that you can fund your practice off of it, right? So I just want folks to understand, like, we don't have to have low reimbursement government programs. Like, you actually, in order for this to work, we'd have to be able to reimburse fairly. I will say this, though, and this is getting really into the weeds. When you reimburse a physician practice for care, there's two fees. One is a facility fee, and one is the provider fee. And one of the things that you've seen is massive inflation in the facility fee.
That's correct.
Because these facilities, these huge corporations, most of the time, right, when you're talking about health systems, can lobby, and then provider fees have stayed somewhat stagnant. And I think that's a problem. I think we need to reverse it, right? And so when you think about seeing your doctor, you're not like, I want to go see X system. You say, I want to see this doctor. And so I think that's another part of the problem. And one of the things we could do under Medicare for All is rethink a lot of the ways we reimburse to get the kind of care we actually want in the system, rather than to just be rewarding big systems for high specialty care.
Great. My next question is about, it's kind of in the same vein. How do we get more doctors engaged in primary care? Because, as you know, most of the talented doctors go into the higher paid specialty fields. And as a Michigan resident, as somebody who loves living in Michigan, I look at the health professional shortage area map across the state of Michigan, and I see so many gaps in care, so many gaps in coverage. One of the reasons I started Plum Health Direct Primary Care was to go into one of those health professional shortage areas, Southwest Detroit, and deliver excellent care for my neighbors and for the people of Detroit. And in some ways, we've helped to alleviate that health professional shortage area locally, but as my practice has gone on, we've seen that health professional shortage area symptom of our broken healthcare system worsen over time. So can you talk about how we get more doctors into the workforce and how do we alleviate some of these HPSAs in the state of Michigan?
First, I want to say thank you for taking the effort and the initiative to address that. I think we need more doctors thinking that way. Of course, not all doctors do, right? You graduate with high medical debt, which is a whole other issue. But your medical school education is extremely expensive. You have a lot of educational debt because of what you chose to pursue, and then you kind of have to pay that back. And that means that a lot of doctors are thinking, how can I pay this back faster? How can I make more money? One of the points that I was trying to make earlier was that we should pay for what we want as a society. And right now, the hardest places to provide high quality healthcare are urban communities and rural communities. Why? They tend to be poorer. More of the patient population tends to be on Medicaid, which does not reimburse very well, and they tend to be places that high income folks may choose not to live. And I think we need to be thinking about how do we make sure that we're reimbursing a little bit more for healthcare provided in urban communities and rural communities to incentivize doctors to say, you know what, like I can make a good living here, providing care for people who need it the most. And so that's another thing that, again, under Medicare for All we could do, right? Because we're really patterning reimbursement around the holes that we have in society when it comes to healthcare. Right now, unfortunately, that's not how the system works. Unfortunately, the care follows the money, and the money follows the people with money, right? And I think we need to be thinking a little bit different around that. And so under Medicare for All, you could imagine, all right, we're going to reimburse a little bit more for the same kind of care provided in a rural community or an urban community to make sure that we have doctors who want to come and practice, and we can address some of the gaps that we have.
Indeed. Yeah, one of my biggest criticisms, going back to that, our first question, there's these large corporate entities that get a lot of subsidies, tax breaks. They don't pay taxes on their hospitals. You can look at some of our large institutions like University of Michigan. The wait time to see a specialist can be 6 months, 8 months. Biggest healthcare provider in the state of Michigan would be Corewell, and they have 70,000 employees and 200 facilities, and they have zero presence in the city of Detroit. These are all symptoms of a broken healthcare system. But my question is, like, how can we hold these larger corporate partners accountable? How can we help them chip in for the greater good?
Yeah, I think again, it's about the incentives that you choose. You know what I mean? Right now, they're going to follow where the money goes, and right now the money ends up being in these corporate mergers and acquisitions. They're able to use their power to get more power, and that's the way that the rules have been written. And I just think in some respects, if you don't like the outcome of the rules that have been written, you have to rewrite the rules. And I think we can rewrite the rules. Like, I don't think, especially the large health systems, they're following the incentives that are at play, right?
Indeed.
And unfortunately, those incentives are about rewarding a very particular kind of money chase. And I just think that we can start to rewrite those rules so it's an even playing field. They're forced to compete with smaller shops that can be more nimble and more dynamic and more patient-centered, and that forces them to be more dynamic and patient-centered. And it also means that if we can kind of rethink the allocation of reimbursements, right? If you're reimbursing more for rural and urban care, then that incentivizes them to really build out clinics in rural and urban communities. So I just, in some respects, it's like the system right now has been corrupted by the power of the largest folks helping to press their incentive set so they can continue to chase it. And I think it's a really big problem. It's a big reason I don't take corporate money, because I don't want to be a part of that system. But if we can actually start to rewrite the rules around what we really want in our system, I think a lot of these players are going to start re-engaging according to those rules. And so I think there's an opportunity here, but we've got to get the incentives right.
Indeed. So my next question is about pragmatically, how do you employ this Medicare for All strategy? I know you've written a book, Medicare for All. I'm about halfway through it, so forgive me.
No worries.
How do you transition our current system to this Medicare for All system? And if the system does become more efficient, what happens to those folks who are employed as the billers and coders and all those sort of roles? Do they lose their jobs, or what happens there?
So we're still going to need people to run the system, right? It's not that like you all of a sudden don't have any sort of folks who are helping to negotiate the transactions underneath healthcare. But I will tell you this: for the 10% of people in this country who are functionally locked out of the healthcare system, all of a sudden they're going to be allowed back in, and we're going to need folks who are able to provide them healthcare. So it's going to create a lot more jobs actually providing the healthcare people need and deserve. The transition on this is going to take time. It's not the kind of thing you can just flip a light switch and all of a sudden we got Medicare for All. It's going to take time to be able to work together alongside different state Medicaid programs, work together with CMS, the Centers for Medicare and Medicaid Services, to roll out a rollout strategy. And I think there are opportunities, a lot of different ways to do it, right? You can imagine a centrally administered version or a more locally administered version. But there's a lot of different design questions that you can answer. The thing that we have to do, though, is sit together and start writing that out and then get it done. And once you do that, you offer some time for the transition and rollout. Like one example for that you could imagine is anybody who's not currently covered, immediately covered on Medicare. Every single person born from that point on gets covered on Medicare. Anybody who opts into Medicare gets covered on Medicare. And then over time, more and more people are covered, and you go from there. Other folks have articulated an approach where you say, all right, 55 and over. Right now, Medicare is 65 and up. So then you start folding in 55 and up. And then a year later, it's 45 and up. And then you just start expanding. And also, there's going to be room for the private health insurance industry. I just want folks to understand this. It's just you're not going to have to rely on them, right? And that's the thing that everybody needs to understand. Right now, we rely on an industry for our health insurance that is incentivized to make as much money as they can, which means denying the care that we need. And I think that you can imagine a private health insurance industry that operates more in a niche portfolio that we don't rely on for the things, for the basic healthcare needs that we have. And so, yes, would this be a big expansion? Certainly. But a lot of the industry that currently exists is going to get sort of baked in, but without the same kind of profit-motivated incentive that they have right now, right? So where your private health insurance industry makes 15% on the top, you have CEOs making 18 million bucks.
Yeah,
that
15 cents on every single dollar that we spend on healthcare goes to those frictional costs, right?
Exactly. So I think all of us agree that we probably want a healthcare system where we spend more on actually providing healthcare rather than, a yacht for a insurance CEO.
Indeed. Now, you can't do this alone. You're going to need a coalition of people who are interested in this. Two-part question. Who are the folks in Congress who want to see this enacted? And is this realistic in the next 3, 5, 10 years? And then what can people do locally who want to see this sort of change? What can they do to, help move this movement forward?
Yeah. So there's a large and growing Medicare for All caucus in the Senate and in the House. In the Senate, obviously, you can't talk about Medicare for All without mentioning great Senator Bernie Sanders. He has endorsed us in this race. I'm really grateful for that. But he's been pushing for a very long time. You've got leaders like Senator Warren, Elizabeth Warren out of Massachusetts, Senator Chris Van Hollen out of Maryland, also just recently signed on. So there's a large and growing caucus of folks who understand that it's not enough to continue to patch what we have. We have to patch what we have while building what we need, right? And in the House, certainly, large and growing community of folks. 2 co-chairs for Medicare for All, one right here locally, Congresswoman Debbie Dingell has been a longtime champion. Her husband was one of the long-serving champions of guaranteed health care. And then you have somebody like Pramila Jayapal, who's also endorsed us in this race.
And a co-author on your book.
Yeah, so she
wrote the foreword for your book.
Yeah, she and Senator Sanders wrote the foreword for our Medicare for All book. So you have folks who understand that this is actually the only realistic idea. Like we can't continue to do what we're doing and expect that people are going to be able to get healthcare in our country. It's just not working. So you've got folks who recognize the path. What do we need to do? We need to grow that caucus. And one opportunity for folks locally is to make sure that your next U.S. Senator is a strong advocate for Medicare for All. I happen to have a set of solutions. Folks can go to abdulforsenate.com and get behind us. I'm sadly the only candidate in this race who is for Medicare for All, and it's large part because I'm the only one who's never touched a dime of the corporate money that's corrupted so much of our politics. If you've taken a check from Blue Cross Blue Shield, you might be a little bit more sentimental about how their CEO feels about their yacht, but I'm not. I'm a lot more sentimental about people being locked out of their healthcare, and so when I stand up and I talk about this, it's because I believe it's what's in the best interest of Michiganders and Americans.
Amen. Well, thank you so much for sharing that, and thank you for your time today, Senator. Senator-elect, potentially.
Yeah, well, I appreciate you, and thank you for your leadership in healthcare. Honored to get to join you, and grateful that you're providing such great care for so many folks in our community.
Indeed. And when is the election?
August 4th for the primary, and then November 3rd for the general. So hope folks will mark that in their calendar and make sure you make a plan to vote. You get absentee voter opportunity for 6 weeks beforehand. There's no reason nobody should vote. All of us need to come out and take our stake in our democracy.
All right. Thank you again, Dr. Abdul El-Sayed, and it's been an absolute pleasure.
Privilege is mine.